uh, with this title slide, I would like to begin. My introductory slides basically focus on the times where psychiatry started to formalize, from Emil Kraepelin, who was a renowned German psychiatrist, where he emphasized that the goal of understanding the essential structure of psychiatric illnesses should be the aim, rather than going specifically into diagnostic criteria. Because psychiatry is unlike other medical or surgical disorders in this respect. And if we come to the current times, one of the most renowned authorities in behavioral addictions and specifically pathological gambling, Dr. Mark Potenza, has frequently emphasized that while we can continue to debate whether these problems are mere habits or impulses or addictive disorders or any other thing, but we have to focus ourselves to providing care to adolescents, their affected families, because people continue to exhibit these problematic behaviors. So that should be our goal rather than being in a very detailed academic exercise. So as we can see, rewarding behaviors are many, but commonly these have to be differentiated from impulse control problems. So in a nutshell, what we can see that the addiction paradigm can be easily applied to these behaviors, specifically gambling, gaming, the broader rubric of internet addiction, food, shopping, sexual behaviors. And as we'll see later, that these rewarding behaviors have been included in diagnostic categories also. After DSM-5, the latest versions of ICD-11 have included gambling and gaming as diagnosable disorders in the main sections, and sexual compulsive behavior disorders is included as a condition for further studies. So now here, the most important word which I would like to emphasize is that behavioral addiction is an addiction where these behaviors are performed for their own sake, not to achieve any end as specific. Like commonly people say, if we compare it to a substance like alcohol, people say that he is having alcohol because he's quite anxious. He wants to treat his anxiety symptoms. Otherwise, he is not alcohol dependent. But when we assess these people, what we find that alcohol dependence is a primary disorder in itself, and anxiety disorders are independently existing. So same is the case with behavioral addictions. Commonly, people try to trivialize the problems related to behavioral addictions by attributing it to other causes, like an adolescent not having any other thing to do, not having a peer group where he can interact and play, and thus he is indulging in excessive video game or internet or maybe gambling. But what we want to emphasize in this presentation is that after a certain point where that neurobiological switch is tipped, despite of being provided with all the other things which we were attributing to, the person would continue this behavior for the sake of this behavior. So this is a behavioral addiction. Moving forward, a lot of terminologies are there, and to go through the literature becomes difficult, like problematic use, hazardous use, pathological use, habitual use. But now we are zeroing in towards the addiction paradigm, of which the major features have been discussed by the previous presenter. So now, why is it a disorder? Because the final step in classifying something as a disorder, as some neurobiological changes are also being discovered and newer advancements are cementing this position. So, as I have already told, that in ICD-11, which morbidity and mortality statistics came out in late 2018, these have been included as disorders. And now for the coming 1.5 to 2 years, these can be diagnosed. So it is not just about a theoretical entity like a problematic internet use. It is a diagnosable entity now. So very simply, the concept of understanding these disorders from a diagnostic point of view needs to be focused on, because at a primary care level, we don't need to be in that exercise where what criteria are being fulfilled or not, but conceptually, the person should exhibit this behavior in an addictive manner. So for that, ICD-11 has basically clubbed the greater number of diagnostic criteria which were there in ICD-10 into 3 major criteria. That is an impaired control, in this example over gambling, where a person wants to gamble frequently, his control over the time that he devotes to it, the money that he spends on it, the number of days he does it goes on increasing. Secondly, an increasing priority or a central tendency towards these behaviors in life starts to exhibit. That is, we can see that at the cost of other important behaviors, a person priority wise wants to gamble. And then there is a significant escalation or continuation of these behaviors despite evident negative consequences like going into debt or going into some legal problem. So this is how an addiction framework can be understood in these disorders, and multiple behaviors like gambling, gaming, internet use, sexual or pornography viewing, food, other things can be conceptualized as a disorder needing treatment and care. And on this, there should be a significant problem in functioning which is visible. Like for an internet or a gaming disorder adolescent, a significant problem in school performance, relationship among families, not devoting time to social gatherings, these kind of things, that is a problem in functioning becomes evident. So these are some basic conceptual criteria towards a diagnostic exercise of identifying or screening these people with behavioral addictive disorders. And conceptually, these criteria can also be applied to other addictive behaviors like excessive eating or shopping and other things, although they are still not diagnosable disorders. What are the major things on which these criteria are based? So major things are salience. That is, these addictive behaviors become one of the most important activities in the thinking, feeling of that person. There is a mood modification. That is, when an adolescent who wants to use video games all the time, he's not able to use it, he would not appear that interested or that happy. But as soon as he gets his gadget, there would be an appreciable change in his mood. Arousal or a rush, something similar to a substance user, like a smoker who gets his cigarette after a long time. Similar to that, tolerance is there, that the behavior amount devoted to it goes on increasing. There are withdrawal symptoms also. An adolescent might react in a very unfavorable way if he's not allowed to use his gadget or not do the online shopping or other things which he is interested in. And another major important factor is relapse. With these behaviors, as it is a disorder, there is a lasting neuroplastic brain change. So even after a month or a few months of change in his habit, chances of going back to that level of addictive use of these gadgets or the other behaviors is very high. So a person who is in recovery from these behavioral addictions can relapse very easily to his previous patterns, given time and options. With this, let's just read through this case Vignette. So James is a 16-year-old boy who spends most of his time online. Now, spending time online for a 16-year-old in itself is not a problem, because online time can be utilized also in proper ways for furthering one's knowledge or other gainful experiences also. But now let us read through other parts of his life. He struggles to make it to school, has missed many days. He has a tendency to procrastinate and supposedly does homework online while actually gaming instead. He spends more than 5 hours online on school, goes to bed around 2. This has led to an increasing conflict at home. And of note, James has been diagnosed with major depression and social anxiety disorder. So now in this case, Vignette, what we can see, there is a significant amount of increased time used non-productively online. There are a lot of problems in functioning, and along with that, there is a diagnosis of major depression, social anxiety disorder. So can we attribute all his online use to his major depression and social anxiety? It cannot be done in every case. Addictive pattern can be independent of these major depression and social anxiety, although they all might be contributing to each other. So with this understanding, now let us move a little fast through the management approaches. So management begins with assessment. A detailed assessment of a behavior is necessary. In this, a detailed history is required not just from the person who is under consideration, but also from the family members, which can be very unlike many physical diseases where we don't actually always require somebody else's report. But here it is essential. The behavior, be it internet, be it shopping, or be it a sexual pornographic use, they need to be assessed not just in plus or minus, whether he is doing computer or he is not doing computer. We have to see in terms of the frequency, the amount of time spent, what he does online, the ability to withhold oneself from doing these activities if asked to. So all these need to be assessed, and all of them become endpoints of treatment. So progress of adolescent in this treatment cannot be just assessed by not using these things, but the degree to which he uses these things. Then evaluation of comorbidities, this we'll discuss in details later. Consequences of these excessive behaviors, contributing factors like temperament, personality, support systems. Some physical and laboratory tests are also there, although not many. And then screening and diagnostic instruments. A basic preliminary knowledge of these is required at primary levels so that appropriate intervention can be done. So now about comorbidities. These are the most difficult to assess areas because many people say that attention deficit hyperactivity disorder is there, so the person wants a lot of rush and he's going on doing his mobile. But treating attention deficit hyperactivity disorder might not lead to a complete change in his online behavior. So the comorbidities are definitely important to assess. Many of them increase the risk for these behavioral addictions. But later on, when this addictive behavior is established, these comorbidities can be independent and they all need to be treated together. Commonly seen comorbidities are other behavioral addictions, like a gambler may also be excessively using online gadgets and other things. Substances, tobacco, alcohol, drugs, frequencies of their use in behaviorally addicted adolescents is also very high. Then other things like neurodevelopmental disorders, personality disorders, trait, mood disorder, anxiety disorders, they all are seen in greater rate than normal other adolescents. Now, other parts of assessment are regarding the environmental predisposition, like what options the child has at home, cultural factors, temperamental factors like novelty, sensation seeking, high risk behaviors, support systems like how many people are there in the family, friend circle, whether it is not there or there. They all help in treatment also later on. And there are some adolescent specific issues which need to be focused. If we find an adolescent excessively indulging in a behavioral addiction, then we need to assess how is he funding his activity, because chances of stealing or leading into a criminal activity are very high. Other risky behaviors, low self-esteem, poor parental supervision, deficient real-life social skills, lack of emotional and psychological support, they all need to be addressed. And then interviewing and forming a rapport with an adolescent is much different and sometimes even difficult than that with an adult, because we have to understand the developmental level, the level at these people are functioning, the classes in which they are studying, their peer groups, and along with all that, a lot of trust, respect, and a feeling of confidentiality needs to be conveyed to these adolescents. A very simple screening test. For example, I have taken as a prototype the internet addiction test by Dr. Kimberly Young, which has been there for use since long. So this overall judges internet use behavior rather than specific purpose for which internet is being used, for pornography or for multimedia games or some other reasons. And then it is very simple to assess and rate people on these, and then appropriate intervention can be advised. Then there can be assessment tools for assessing the severity, like in case of gambling, problem gambling severity index, which is also very easy to apply, and you can get an instant result in terms of the risk stratification where the person falls and the level of intervention he requires. And now coming to treatment goals. So treatment goals is very different across different types of addictions. So let us compare it with maybe smoking. So there is nothing like safe smoking. Treatment goal is to quit smoking. But in terms of internet use, can somebody be totally off the internet? So abstinence is not a goal. So there can be a lot of goals. Harm minimization can be a goal. Improved or balanced use of internet can be a goal. Improvement in health, social, occupational functions, quality of life can also be a goal till the time the person is able to change his internet use habits. So compared to that, now if we see gambling disorder, then any gambling is not good. So here the goal can be complete abstinence. So this also needs to be very flexibly understood, that the goals will be very different for different types of behavioral addictions. Now coming to pharmacological interventions first, because pharmacological interventions for addictive disorders per se are not approved in adolescents. Pharmacological interventions for most of these disorders per se are mostly in studies and trials, but not part of standard guidelines. Although treatment for other comorbid conditions like for anxiety, for attention deficit hyperactivity disorder, these need to be done. Now coming to the mainstay of treatment, psychosocial interventions. So psychosocial interventions include psychological interventions or psychotherapeutic interventions as well as social, where different levels of social interactions like family, peer group in the school or larger community, all of them can be integrated to different levels. So these are known as psychosocial interventions. So brief intervention is an approach to target any maladaptive behavior, not just gambling or gaming, where these frames, this acronym, where a short interview is done, a feedback of the personal risk to the patient is given, like you are doing a lot of gambling, you will lose a lot of money, you will run into problems, and your chances of increasing are high. So this is an example of a risk. And responsibility of the patient for personal control. A simple question could be, how do you think you can change this behavior? With whom lies the responsibility? And a clear advice to change. Sometimes when we say कि चलो देख लो आप जितना कम कर सको, rather than this, a clear advice to change. No, you have to stop gambling. You have, or for internet, you have to do a balanced use. You should not go to pornographic site. Clear warnings or instructions can be given. And then menu of ways to reduce or stop these behaviors can be given. Like you have a pharmacological option or different kinds of psychotherapeutic options. And then empathic counseling style and a self-efficacy, that is, you can do it. So this requires not more than 5 to 10 minutes at a primary care level. So this needed to be discussed in the greater details. Now, compared to this, there are more intensive psychosocial interventions where the motivational interviewing approaches are there. So motivational interviewing approaches are in some way more elaborated brief interventions, or where there is a greater amount of time given to adolescent, where the therapist is mostly listening and just giving nudging or slight suggestions so that the person himself comes to the conclusion that I want to change my behavior. It's very effective, especially for adolescents who are not currently thinking about their behavior. And then there are psychosocial interventions in terms of cognitive behavior therapies, which can be more intensive. Then coping skills training, a lot of time it comes across that the adolescents are not able to cope well with other areas of life. There are frustrations. Then life skills training, like interacting with others, managing emotions, other things. And then there are 12-step approaches also, where a person is directed in a similar way, like Alcoholic Anonymous and other things, which is another way. And then there are other approaches like contingency management, peer-led approaches, school programs, family-based approaches. And lastly, there is prevention. So when we know that so many adolescents are getting into these problems related to gadgets and other internet and other things, then we can also initially discuss about safe use of these things or prevention. So there are a lot of practical tips for parents. There are guidelines from various pediatric societies also, psychiatric societies also, where this is to stop those behaviors which are totally harmful like gambling, and behaviors like internet use, where it is a requirement also there a safe use with some clear boundaries and limits can be discussed. And to conclude my discussion, I would say that these disorders are diagnosable primary disorders, so we should not trivialize them, especially gambling, gaming. And then they are not merely manifestations of other disorders, that loneliness leads to gaming or anxiety leads to gaming. It doesn't happen this way only. And dysfunction, distress is a lot. So those who need treatment should be provided that treatment. Thank you for your patient listening. Thank you to the panel.
Thank you so much, Raghav, for a wonderful, informative, and practical approach to the management of these disorders. And as you rightly said, that the prevention can also be a part. We can always keep a check on the adolescents.
Can we take one question, Dr. Raghav?
Yes, for sure, you can.
How to reliably assess comorbidities? Are these diagnosable, recordable disorders? Should they be a part of routine assessment of adolescents?
Right. So very briefly reply to these. In countries where the prevalence of these internet addiction and other related problems are high, there they are being considered as a part of routine assessment of adolescents, like the Southeast Asian countries, Korea, in Middle East and other countries. In our country, the maximum rates also which are being come forward are like 7% or 10% in some specific groups, college students or adolescents. So here, in those specific groups, it can be considered as a routine part of assessment, like a few questions: how much internet do you use? How much time you spend online can be asked. But in a context like a village context or a rural setting where we don't expect these, then they should not be part of routine assessment. Second part, comorbidities. So comorbidities can be reliably diagnosed through a detailed psychiatric interview. Wherever during the assessment that these behaviors are also associated with some anxiety or attention deficit or those kind of issues, then you should go in detailed assessment, and where required, both disorders should be treated.
Okay, thank you. To deal with the mobile addiction of school-going children by Mr. Satish Avasti. Who will going to answer? I think Dr. Raghav.
Dr. Raghav.
So, to deal with mobile addiction of school children, so it's a, like as we discussed, that mobile phone is being used for what? That is the first thing to see, whether for gaming or social media or for what purpose. And then we have to assess that behavior in detail, whether it is how harmful, whether it is to the limit of an addiction, whether simple behavioral measures, as Sir has discussed, like giving them some limits and then asking them to indulge in other activities can help. If that cannot help, then some more intensive interventions, including consultation with a doctor, would be required. So that would be my answer.
Which substance abuse is common in Rajasthan in adolescents? Is there any causal relationship established between broken families and substance abuse by adolescents? Dr. Raghav?
Yeah. So substance use, it means the addictive substances. So see, overall, the most common addictive substance is tobacco. And after that, alcohol and cannabis related substances are commonly used by adolescents in Rajasthan first. And regarding the second part of question, what is the evidence for a correlation between broken families and these addictive behaviors? So there is evidence to link both of these things. And there are multiple mediators to that relationship, which includes, first of all, poor parental supervision, overall increased emotional expression or stress in the family, increased poor modeling behavior from the parents, and other moderating pathways are also there, but there is correlation established.
Dr. Rajiv Jain to Dr. Raghav, why they are not impulse or obsession related problems? How to avoid stigma related to diagnosis of addiction?
Okay, so first regarding impulse. So impulses are generally not pleasurable. They are more like impulse by definition is an action without a very prolonged or a thought given to it. So the thought and action are done simultaneously. So there is a urge which is created in an impulse which needs to be discharged rather than a very pleasurable kind of a sensation. Let's take for example hair picking or hair pulling, nose picking. Those kind of things are impulses which are not always pleasurable, but you need to discharge. Pyromania, yeah. And now coming to obsessions. So obsessions are generally absurd and intrusive to a person. And these are also not generally enjoyable. They are mostly described as something which you do not want to think about, but keeps on coming into your mind, and you give into it just to relax yourself or distract yourself from that thought. So they are also not exactly pleasurable. And while addiction, so addiction is a broader term in which there are stages where there are predominance of impulse, then there are later stages where there is a predominant of an obsessive and compulsive kind of a behavior. But addiction is
initially it is pleasurable.
Yeah, initially it is pleasurable, more of an impulse to take a binge, take excessive amounts. Then as you progress in the dependence or addiction, then it becomes compulsive. You are not able to live without it. You become preoccupied of taking that substance. But individually it is neither only a obsessive compulsive kind of a behavior or only a impulsive kind of a behavior. That's it.